Introduce Dr. Kenneth Koch, professor of internal medicine, section of gastroenterology with Wake Forest University Baptist Medical Center. And he will be presenting on gastroparesis in pain. So with that, Dr. Koch, I will leave it to you.
All right, everybody, good afternoon, and okay, I hope you can hear me.
We can.
Okay, and thank you all for Andrea and group for the invitation to talk today about this topic, gastroparesis and abdominal pain. I'm here in Winston-Salem, North Carolina, and we're having a beautiful day of sun and 80, and I hope you're all having a good day as well as we get started here. Gastroparesis and abdominal pain. I'm going to go through kind of like how I think about this problem and how perhaps your doctor is thinking about this, and look forward to your questions as well. I have some disclosures here to show you. I will be talking a little bit of data from our Gastroparesis Clinical Research Consortium. The NIH believes this is an important problem, and so we're beginning actually the 15th year of a registry and a variety of studies to try to understand the pathophysiology and some of the future treatments for gastroparesis. So in this particular set of comments, I think it's important first to understand how the stomach works. The stomach's actually a very sophisticated muscle. Patients often are surprised when I say that, but it's a very sophisticated muscle. I'm going to show you some slides about the work it does, and then what can go wrong in the setting of gastroparesis. And then we're going to talk about different causes of abdominal pain, because there are causes of abdominal pain that are from the stomach, but you really have to think about non-stomach gastrointestinal causes of pain as well. And then I'm even going to introduce some movement, that is body movement, related causes of abdominal pain. So you see, I think you and the physicians that take care of you don't necessarily, shouldn't necessarily blame pain in the abdomen on gastroparesis. You'll see why in a moment. But first, let's talk about the stomach as a muscle. So here's a picture of the stomach, you know, and you can see there's a fundus, there's a corpus, there's an antrum, there's a pylorus, and it's actually a very interesting shape, but its job is to initially relax. And those green things are actually supposed to be food. You know, I know some of you cannot eat solid foods because of gastroparesis, but a solid food is received by the stomach must relax. The fundus moves the food into the corpus. The corpus fills with acid and pepsin, and then a series of peristaltic waves, gentle peristaltic waves, move down across the food. They move across the stomach, and they gently mill the food into tiny bits. It's a very sophisticated mill. So what I'm showing here is after a certain amount of mixing, the fancy word is trituration, but this milling, a certain amount of the meal is ready for emptying. And to do that, the peristaltic wave pushes some of this, a small 2 to 3 ml, actually, of this nutrient suspension through the pylorus and into the duodenum. And then the next cycle recurs, and then the next cycle. And over many hours, our solid meals are received, but then it takes hours to mill and gently empty the food particles into the duodenum. Then a whole nother series of digestive enzymes are released from pancreas, the gallbladder helps, and the food particles then are ultimately absorbed in the small intestine to become us. A very crucial operation. Then the stomach prepares that food. Well, it's so important that these peristaltic waves are paced. Stomach has a pacemaker, and it's called a slow wave because if you can see my pointer here, there's a pacemaker area on what we call the greater curve of the stomach. It's between the fundus and the body. And these slow waves shown here, recorded from the surface of the stomach, they actually go around the stomach very quickly, and then they migrate slowly across the stomach to the pylorus. And when this wave is finished, the next one begins. So it's a series of waves. Think a series of gentle waves rolling over the food, doing the mixing, and then emptying through the pylorus over time. Fundus doesn't really have that rhythmicity. And over the years, one of the things I've been interested in research is what's called an electrogastrogram, and that is recording these electrical rhythms from electrodes placed on the surface of the abdomen. So we try to see, is there a 1, 2, 3 cycle per minute rhythm? That is the normal rhythm of a stomach that has enough pacemaker cells. We actually know what they're called. They're the interstitial cells of Koch. Those are the pacemaker waves. If you have enough of those, you're in a nice 3 cycle per minute rhythm, which guides the electrical activity, which provides the contractions, which does the mixing. Very simple, isn't it? So your stomach is a complex neuromuscular organ with a big job to do. Well, guess what? In what we call gastric neuromuscular diseases, all of those things can go wrong and have been shown to go wrong. The fundus may not relax. People feel very full with that, with a very tiny amount of food. You may have a weak rhythm, and in its place, there's dysrhythmias. It sounds a lot like cardiology. Tachygastrias, bradygastrias are inefficient rhythms. They are bad rhythms in that the stomach then cannot empty in that efficient way. It can't mix and empty efficiently. And with time, the stomach can become dilated. Hypomotility means weak contractions, and the food just doesn't get out. Another variable is the pylorus. It can be in spasm or not distend very well. There can be hypersensitivity because of vagal afferent issues. So wow, in some patients have all of these problems, and you see it just doesn't work very well. There's lots of symptoms after you eat, of course, because that's when the stomach's supposed to work. If you don't eat, this organ doesn't have to work very hard, but once you eat, it must do its thing. And a lot can go wrong with the stomach in terms of its neuromuscular function. So let's talk about gastroparesis. I mean, the definition is pretty simple: delayed gastric emptying of a test meal. Usually it's an egg beater's sandwich. In the absence of mechanical obstruction, we want to make sure there's no ulcer at the pylorus or anywhere that would cause these symptoms. And here's the symptoms. And notice I say associated with gastroparesis. I don't say symptoms of gastroparesis. They're associated, because look at the symptoms. Early satiety, filling up real quick with a small amount, feeling full for hours and hours, nausea, maybe vomiting of undigested or unmilled food. You can feel bloated, abdominal discomfort, and some folks have pain. And in our NIH consortium questionnaires, we found almost 40% of patients with gastroparesis say they have severe pain. Now, the study didn't really say where the pain's from. And so you see the symptoms that are associated with gastroparesis, including pain, are very nonspecific. These symptoms you can see in a lot of diseases, which I'm going to mention shortly. So you don't want to necessarily blame all of this on the gastroparesis, because when there's abdominal pain and gastroparesis, I like to work up the causes of pain quite separately. I want to make sure there's nothing else causing the pain. And so one of the things I should do with every patient, and you might do it to yourself and say, what about my pain? Back in medical school, we were taught PQRST. You don't just say, oh, doctor, I have abdominal pain. And the doctor shouldn't say, oh, I get it, you have abdominal pain. No, that's not good enough. Sorry. You got to ask more questions. So yeah, okay, you got pain. What's the quality? Is it burning, like acid burns? Is it sharp, like nerve pain will be sharp and burn? Is it dull and crampy? That might be GI. What's the quality of the pain? Where does it radiate? Does it start in the in the upper abdomen and go into the chest? Does it go through to the back? Does it go down to the groin? Or where does it go? Or is it in one spot? Severity, of course, you can do the old 1 to 10. And timing, really crucial. Is it worse after you eat? Is it worse after a bowel movement or with a bowel movement? Is it worse, I don't know, when you stretch or cough? Timing. Really important to know those characteristics because, that pain that has been associated with your gastroparesis could be from something else. And so that's my number one message. So let's look at a few of these abdominal pains in patients with gastroparesis. And I call them stomach causes of abdominal pain, like if you had gastroparesis, or even these symptoms in the presence of normal gastric emptying. But nevertheless, there's also non-stomach, but gastrointestinal causes of abdominal pain. And then what about non-stomach, non-gastrointestinal causes of abdominal pain? Wow, I have to find simpler words for those, don't I? But anyway, the point is here, the doc needs to review a complete differential diagnosis for abdominal pain. And by the way, I have patients who have pain from all three of these areas. So we have to dissect out, divide and conquer, and understand the pains that a patient with gastroparesis may have. All right, how about, let's try this one on. Non-stomach, non-gastrointestinal causes of pain. Well, the one I find almost every time I go to clinic is called abdominal wall syndrome. So this is not even inside the abdomen, it's in the wall. And what happens is there can be what I call point tenderness. I mean, it hurts on a spot. And frequently that spot is an old scar. And the old scar may be from a laparoscopic cholecystectomy. It could be from any scar. Sometimes there's not a scar, but in my practice, there's usually a scar there. And somebody has overlooked actually saying, where does it hurt? Can you put one finger on it? Because, a pain from the stomach and the gastrointestinal tract, usually it's a bigger area that hurts. It's not a point. And so Dr. Kenneth in 1926 described, he said it's his sign, but he said, when you have this kind of pain, you're trying to figure out, is it in the wall or is it in the abdomen itself? Put your finger on the point. Patient says, oh yeah, that hurts. It's a 5/10. And then you have the patient flex their head up until the abdominal muscles contract. It's almost like a crunch. You're going to bend forward till the muscles contract. And if that action ratchets the pain up to a 8, 9, or 10, you say, well, that pain is from the wall. It didn't get worse with eating. It didn't get worse or better with the bowel movement. It got worse with that crunch. And so I do this all the time. And in fact, in one of our recent NIH studies, we found that 20% of our GP patients had a positive Kenneth sign. So you see, that wasn't pain of the stomach. This patient with gastroparesis has a pain, but it's actually from a totally different mechanism. So another strange one I come across occasionally is xiphoiditis. Who hasn't heard of xiphoiditis? Well, it's actually inflammation at the tip of the breastbone. There's a little piece of cartilage there called the xiphoid, and that can be inflamed like arthritis almost, and people think that's where their stomach is, and it gets missed as well. So these are a couple causes of pain in the abdomen that are not related to the stomach or the GI tract at all. And so I send these folks to pain clinic where they have a whole variety of different treatments and help that kind of pain. All right, well, that's always nice to find because that can be treated in a fairly straightforward way. But what about non-stomach GI causes of abdominal pain in a patient with gastroparesis? We'll have patients who have atypical GERD. It's more of a chest pain. It may be low in the chest, almost in the upper abdomen. So I want to make sure the acid is very aggressively treated. Gallbladder, if the gallbladder is still in, well, when patients eat, they can have abdominal pain, some nausea, some bloating. It can be very, you might say, not classic gallbladder presentation, even without stones. So we look for the gallbladder emptying delayed or rapid. A pancreas problem can result in pain after eating, and perhaps a blood test or an abdominal CT will be needed to look at the pancreas. Small bowel. Well, a lot of patients with gastroparesis or constipation have another organ involved, and that is the small intestine. It has too many bacteria growing in the small bowel because small bowel motility is not normal. It can be sluggish. And when people eat a meal and they start emptying the meal, half hour, 45 minutes later, the small bowel bacteria make a lot of gas that can create pain, bloating, and it's actually not the stomach that's causing the symptoms. And remember the transverse colon. Who could forget the transverse colon? The transverse colon is the part of the colon that goes right transversely across the abdomen, left to right, right to left, before it goes into the sigmoid descending colon. Well, sometimes it can hurt, and people eat. There's a gastrocolonic reflex, and actually it's the colon that's causing some postprandial symptoms. Could be severe constipation and irritable bowel syndrome, and so on. So you can see there's a lot of organs in the abdomen, and it's not necessarily just the gastroparesis causing the problem, and diagnostic tests can be ordered to sort this out. All right, stomach causes of abdominal pain. Well, this is why our patients go to the gastroenterologist eventually, and of course we like to do endoscopy, and because that's going to show us mucosal diseases, the lining of the stomach. We can see gastritis, ulcers, cancers, obstructions at the pylorus with our endoscope. But most of my patients and most patients with gastroparesis have basically normal endoscopy. And so what about the neuromuscular dysfunctions in gastroparesis that could cause pain? I mean, this is supposed to be a paralyzed stomach. How does it even cause pain? Well, I think there are two mechanisms really that you could consider. One, I mentioned it, and that is that in some patients, the fundus and I think the corpus itself, it doesn't stretch very well. It's forgotten how to relax. And as it stretches, it can hurt. You can go into a gastric dysrhythmia, and there's nausea and pain when people try to eat. The stomach becomes hypersensitive to that stretch as well. So this is I think more common than is usually appreciated. And then the other that's a big focus right now of research in the area of gastroparesis is the pylorus, the valve that regulates gastric emptying. It can be in spasm. It can have poor distensibility. It's not stenotic because you've had an endoscopy and the scope goes through, there's no ulcer. It's a neuromuscular problem of the pylorus. That pylorus can go into spasm and cause pain. I think pain on the right side, that many people get their gallbladders removed. And guess what? It wasn't the gallbladder, it was pyloric spasm. So this is tricky business in the abdominal cavity. There are a lot of organs in there that need to be considered. So, most patients then, when they have these problems of nausea, vomiting, the symptoms we associate with gastroparesis and pain, they will be, they'll get trials. PPI would be the acid suppressing agents. Prokinetics would be the one or two drugs we have that might promote gastric emptying. But you get an endoscopy to look at the mucosa, and it's normal. There is no gastritis or H. pylori. There is no esophagitis or duodenitis. And now we have nausea, vomiting, pain of unknown origin. And this is where we start to look for gastric neuromuscular dysfunction. And what we do here is a lot of gastric emptying studies and electrogastrography. And we do this in the context of working up those other possibilities of pain when it makes sense to do that. So the gastric emptying study, the classic one, it's low fat egg beaters. This was the original study. We're looking at time. We're looking at percent of the meal retained over the 4 hours. So initially there's not much is emptied, maybe 20% in 60 minutes. This is kind of a lag period. A lot of mixing has to happen before you get into this more linear emptying. By the end of 4 hours of work, the stomach in women and men should be less than 10% of the meal remaining. So anything above 20% is probably moderate gastroparesis, 35% maybe is getting into the more severe gastroparesis. After 4 hours of work, you're up in here somewhere. You didn't get it emptied, and so we call that gastroparesis. How many of the symptoms you have are related to this it remains controversial. It doesn't correlate very strongly. But electrogastrography, on the other hand, looks at the stomach's electrical rhythm. There's 3 electrodes placed on the abdomen. We're looking for the electrical events below. And so we look for these 3 cycle per minute waves. There's a minute, this is a healthy person. In 5 minutes, they're asked to drink till you're completely full. This healthy subject drank 750 ml, over 20 ounces in 5 minutes. And we looked to see what the rhythm of the stomach did. And it's much stronger, regular 3 cycles per minute. But this gets digitized, and you see 3 is good. When you're in a rhythm between 2.5 and 3.7, things are good. You have enough pacemaker cells, and after the water load, we get a lot of peaks here in the 3 cycle per minute range over the 30 minutes recording. Bad rhythms, bradygastria too slow, tachygastria too fast. And that's kind of how we look at electrical rhythm in the context of these other issues. But just to point out, this water load test, satiety says, drink water till you're completely full over a 5-minute time period. Sounds pretty simple, and it's interesting. Healthy subjects drank on average 550. All healthy subjects ingested more than 300. But the healthy subjects, you and I, perhaps, we feel full, but it doesn't produce nausea, bloating, discomfort, or pain. But in patients, it absolutely brings on these symptoms, and 20 to 30% of them drink, less than 10 ounces in the 5 minutes. So they don't stretch very well, and they really feel it. And so this is a way to look at that relaxation part of the stomach while we look at the stomach's electrical rhythm. And so when we did this in our a large number of patients in the NIH gastroparesis registry, if we just look over here, these people had gastroparesis. They had this electrical study, and almost 2/3, had a bad rhythm. But the interesting thing is about 1/3 had a normal rhythm. And so this is a very interesting group. And I'll tell you, this group kind of leads us to thinking about the pylorus as the problem in these patients and pyloric therapy. For instance, this was a diabetic patient with severe gastroparesis, but they had a really normal rhythm. And if you do that running spectral analysis, this looks very normal. And it's so normal that it makes us think, well, why they have gastroparesis if they have enough rhythm cells? This is the pattern that makes us consider pyloric dysfunction. And so it's a group that we look at. The pyloric dysfunction may be part of the pain. It's certainly part of the other symptoms that if they have those related or associated with gastroparesis. So in those patients, in particular, we're interested in then either using a balloon here at endoscopy, that's the pylorus being stretched. And here's the pylorus in this other patient, and we're injecting Botox around the pylorus. It's a circular muscle ring, and it can misbehave. And so we're trying to relax it or stretch it. And so, like I say, that kind of patient I just showed you had actually a strong rhythm, and but we think the problem was here at the pylorus, and so they were getting pyloric therapy. So basically what we're doing is trying to be a little bit more sophisticated by subtyping gastroparesis. And if the electrical activity is in this normal range, we start with balloon dilation or Botox. And then you may be hearing or reading about a GPOM, which is a myotomy. It's a cutting of the pylorus during endoscopy. And the surgeons have had ways to cut the pylorus for years, decades. They know how to cut the pylorus. Well, then you ruin the sphincter, it's gone. And you hope, that food will empty better. So this area is pretty new, and there are publications coming out about this approach to the pylorus. Here at Wake Forest, we like to do at least 2 sessions with balloon or Botox and hear that the patient says, wow, I'm eating better, I have less pain. That really worked. But, it works for either a month or 3 months or 6 months, but these are not, permanent help. Although some people would prefer to have that repeated than do a procedure where the pylorus is actually cut. On the other hand, we've had patients who've had pyloroplasty and done very well, but I think this is what's being researched right now. On the other hand, if the patient has a poor water load test, we of course, that gives us an objective way to say, well, look, you couldn't tolerate 240 ml of water, it made you hurt. This is a rationale for, staying below that limit, try to go forward. We don't have very good medicines to relax the stomach. We use things like buspirone. The NIH has a trial right now of buspirone to see if it can help those early satiety fullness symptoms. You'd think nitrates, but in this area, we just try things. There's not a lot of solid placebo-controlled trials for medical treatment. On the other hand, if there's gastroparesis and these dysrhythmias, once again, we tend to try drugs. I list a number of them here. Some are not available. This one is for cancer chemotherapy, nausea. Some are to try to make the stomach work harder. Some are just to treat symptoms. The Entera is the gastric stimulator for patients who fail all drugs. They still have nausea and vomiting, and this is the electrical therapy through the Entera device. These patients may also have a gastric relaxation problem, you see, and they may be helped with some other dietary advice or trials of these drugs empirically. These patients may also have a pylorus problem. There's no reason they couldn't have a pylorus problem as well. So you can see there's many considerations here when we consider the stomach itself and the symptoms associated with gastroparesis. So take-home points, I would say this, for patients with abdominal pain and gastroparesis. Yes, it could be the stomach, a sensitivity to stretch, or pylorospasm, and we have some ways to address these. Remember the PQRST, because we go over that, some of those details may begin to suggest the pain really isn't the stomach, and maybe some other diagnoses should be considered, such as the ones we talked about there, everything from atypical GERD in the esophagus to the other abdominal organs. And many of my patients have certainly, 1, 2, or 3 reasons for their abdominal pain. And I always look for the abdominal pain from the abdominal wall syndromes and Carnett sign and xiphoiditis, and because those are pains you can take care of. They can be miserable pains, severe pain, and if the pain clinic can really reduce that pain, well, that's just a win. So those are the non-stomach, non-GI causes. So basically, if there's abdominal pain and gastroparesis, please work up the pain separately. Figure out the pain. Is it really from the stomach, or is it from some of these other diagnoses? Thank you. Those are my comments on gastroparesis and abdominal pain. I'm happy to take any questions.
Well, thank you, Dr. Cook, for your thoroughness in covering gastroparesis and pain. I mean, it is a topic we have difficulty finding someone to address and difficulty for patients to find a resolution. So with that, why don't we jump into some questions, because we are getting a lot. We have one for you, Dr. Cook. As newer and more innovative therapies for gastroparesis develop, we at times rely on creative or old standbys. How might compounds like antihistamines, for example, Benadryl, periactin, or the H2s, pepsid, and or probiotics temporarily mitigate pain without the need to rely on compounds like opioids? Are there drawbacks to these approaches?
Okay, well, that's a good question. And I think because we don't have that many truly proven therapies and patients continue to have symptoms, every patient is trying different things all the time. And I would too. So I don't mind Benadryl. And if this is a question about pain, yeah, maybe Benadryl helps for non-specific reasons. If a PPI or a Pepsid helps, that's interesting because those drugs just suppress acid. So if they're helping, part of the problem is acid, and it's acid in the stomach, and that's a win. You can just keep drilling on that. Opioids in my patients, I go like, I say, oh my gosh, you know, opioids are reversing, are combating everything I'm trying to do for the stomach, and opioid, what's the word, does combat. Opioids, I've studied them, they create dysrhythmias. Opioids slow the gastric emptying. So opioids cause constipation. Opioids slow the small bowel down. As opioids slow everything. So I have patients on, who have severe back pain. They can't get off their opioids. I get it. They need to have a life away from pain, but then it makes the stomach or the GI tract. I say, well, what can I do? So that's very difficult. And if you can get off of the opioids or reduce them or get to your pain doctor and say, what can we do? That's the best in terms of these other GI motility problems.
Great advice. We have another question here. Would pancreatic enzyme replacement be helpful to treat adverse symptoms of gastroparesis?
Yeah, believe it or not, no great big study on that. And theoretically, if your pancreas is normal, the enzymes really shouldn't help. The gastroparesis symptoms that are associated. Now, if you tried it and if you had abdominal pain that your docs had never figured out, and you said, I want to try some enzymes, I want to try some pancreatic enzymes, and you took the enzymes and your pain got better, well, that's a point towards that pain was from the pancreas. And you were helping your weak pancreas by providing those enzymes, and thus it didn't have to work so hard. By the way, the pancreas has to work hard after you eat, the gallbladder has to work hard after you eat, and I talked about the stomach has to work hard after you eat. So maybe the enzymes were actually helping the pancreas. And if it helped your pain, maybe those two things should be tied together. You see, that's how some of these responses to drugs might lead you to another diagnosis. But I do not use enzymes for gastroparesis itself.
Okay, let's jump into another question. Have you ever worked with any patients with neuromuscular esophagus disorder who also have gastroparesis?
Yes, those neuromuscular disorders of the esophagus can range from achalasia, which is a very weak esophagus, but a strong lower sphincter. A percentage of those folks can have gastroparesis. And we see many patients with reflux esophagitis, they've got GERD, they have contraction problems of the esophageal body, their lower esophageal sphincter doesn't work very well, they have a lot of GERD, and we think almost 30 or 40% of those patients will have gastroparesis. So it's actually quite common to have GERD and gastroparesis. The other one that's associated would be achalasia. So yes, definitely happens.
We have one here. Hello, my non-SBS daughter just had an endoscopy due to stomach pain. It was all normal except for mild chronic inflammation of the stomach. H. pylori was not seen. If it is H. pylori, could it be missed on biopsy from endoscopy? What does mild chronic inflammation mean? Her pain has pretty much resolved.
Yeah, that's good questions and quite common findings. Almost all of my patients, even with gastroparesis, will have mild to moderate inflammation. So that inflammation is in the endoscopist, eyeballs. It's what we see, and it probably doesn't mean very much. I biopsy a lot for H. pylori in those situations, and I think there is probably better than the blood test, which just tests for antibody. We're actually looking for the H. pylori itself in the biopsy. So I like that information, as you don't have H. pylori when it's negative. And I think if it all went away, that's awesome, because I think inflammation of the stomach can come and go a lot, whether it's acid or food related. But all of those things you said sound like they were mild to not even relevant to her symptoms, which are better. And so happy ending there.
I think we have time for one more question. We're already behind, but I know you had a couple more here. Our daughter has a JPEG G-tube for drainage and Hickman line for hydration electrolytes after SMAS. When we ask about other tests, we are told she has non-functional anatomy. Should we accept this, or should we be pushing for further testing and assessment? She is on opioids and still has significant pain.
Yeah, that sounds very complicated. I think the operation was, I think you said SMA, superior mesenteric artery syndrome.
Yes.
Yeah, they kind of have to move some bowel around, move the artery around. Yeah, that operation was supposed to help. And so if it's not helping, if it didn't help anything, then yes, it's reasonable to say, well, I'm not any better. I'm still on opioids for pain. Is there some other cause? That's exactly what my kind of lecture was about. If there was gastroparesis and this was supposed to help, well, did it help the gastroparesis or not? If it didn't help the pain, well, then you should ask, is there something else? Mm-hmm. And see what discussion you could have about, and also go over the PQRST if you can. But this is complicated when you get into all these tubes that are supporting nutrition and hydration. That has to be worked out.
Mm-hmm. Okay, should we try and get to one more question? We could do it.
You're in charge.
All right, we'll try this one really, really quick.
I'll make a short answer.
I know. I'm not sure any of these are going to be short answers, but if I manage to keep anything down, food or drink, I will develop pain to the left of the umbilicus, which takes the form of visible and painful spasms. It will go on for up to 20 minutes or so, and it's distressing. I was told I might have something to do with the gastric stimulator, but I experienced it even when the stimulator was out of power between changes. Medtronic had never seen it. It doesn't occur with tube feeding. No one has been able to determine, has really investigated it. Any thoughts?
Well, if it's a pain to the left of the umbilicus, that's a bit low for the stomach. Stomach is really kind of high, up under the left ribs, left side, up to the middle. That may be a little low for the stomach, but you know, again, it's the PQRST. Is it if it hurts 30, 40 minutes? If it's hurting an hour after you eat, it could be small bowel bacterial overgrowth. Sometimes I ask patients, what are your bowel movements like? You know, and they say, well, I go every 4 days. And I say, really? And it's a little pellet. I say, well, maybe when you eat, that's that gastrocolonic reflex, and that's your sigmoid colon that you're feeling in spasms. So there's, I mean, small bowel overgrowth, a colon that's not quite working because you're not eating right anyway, not right, but you're not eating a lot of, you know, fiber, a lot of soluble fiber that would give you a big bowel movement. So these can be tricky. But there's a couple ideas to consider, and as well as the stomach. And although, as I said, it's a little low, a little to the left, and this is why you could take that story back to the doctor and go over that one more time with them and say, you know, what are there some other possibilities here?
Mhm. Well, with that, I think we'll have to end it. So, Dr. Cook, I guess this just means we'll have to have you back for another mini meeting.
Okay, well, thank you for having me.
Thank you so much. We really appreciate it. It was an excellent